Let us begin rather. So this image, it shows you a patient with multiple keloid scars. So now you have to learn to differentiate between a keloid scar and a hypertrophic scar. So now the main difference is hypertrophic scar, this is the lower image, it is within the incision line. So wherever the incision line is, it does not outgrow that, right? But with keloid scars, what happens is, see, there will be no scar or no wound which will be in this shape, right? So keloid scar is a scar which grows outside the boundaries of the incision. Now what you can see over here is this is a measure. So this instrument here, this is a measure, and it is used to mesh a split thickness skin graft, right? So the person over here, he is introducing the mesh, and here they are pulling the mesh out, and as it is being pulled out, you can see these meshes being formed, the holes, the small holes being formed. The advantage of this is it prevents seroma formation, prevents hematoma formation, it increases the surface area as well. So this is the measure. How do you identify the measure? This instrument, you see this person, he is pressing onto that. See, he's applying pressure and it comes out. Okay, so now this is a kind of wound dressing which is called a vac dressing or a vacuum assisted closure, right? It is also known as negative pressure wound therapy. It is also known as negative pressure wound therapy. And how you identify this is, so when I zoom in, you can see that there is some wound present over here, right? And you can see this black structure over that. That is the foam. So what happens is the foam absorbs all the exudates from the wound, and superficial to the foam is you have this uh, thing over here which keeps the foam in place, and this is connected to a suction. So whatever exudates are formed can easily be suctioned out. Now this is a degloving injury. This is a degloving buttock injury. So what do you mean by degloving injury? Degloving injury is an injury where the skin and subcutaneous fat are, it's like removing a glove basically. So what happens is the skin and the subcutaneous tissues, they are separated from its underlying deeper structures. So here you can see a degloving injury of the, this is the ring finger, this is the little finger. Okay, what surgical procedure is being done over here? The surgical procedure that is done over here is a fasciotomy, right? So how do you identify it as a fasciotomy? First is via the incision. So you can see a longitudinal incision. You can see a longitudinal incision, and this thing that you can see popping out, this is the muscle. This is the healthy muscle which is bulging. So once the healthy muscle is seen bulging, that means the procedure is being done correctly. Okay, so this is an image of necrotizing fasciitis of the anterior abdominal wall. So you can see a Foley's catheter over here. This is the right lower limb. This is the left lower limb. This is the, don't know whether it is a male or a female, but this is the perineum area. And this that you can see over here, this is the necrotic patch. It is, suppose if you rupture it, you will get something called a dishwater fluid. The fluid that will come out is called a dishwater fluid, right? Then you can see erythema, redness, or inflammation all around it. Fine. All this is the erythema redness. Now this is necrotizing fasciitis of the anterior abdominal wall. Necrotizing fasciitis of the anterior abdominal wall is also called Melanese gangrene. Supposing there is necrotizing fasciitis of the scrotum, that is called Fournier's gangrene. So this is a pressure ulcer. How do you identify it to be a pressure ulcer? So firstly, by its location, pressure ulcer is present on the sacral prominence, on the heel, on the occiput, on the greater trochanterus, wherever the patient is, wherever there is contact with pressure for a long time, right? Now this is a dirt ingrained scar. So this patient, see, this is the scar. This entire thing is the scar, right? But it looks black in size. It looks black in color. Why is that? That is because whenever the patient would have had a wound, the wound would not have been cleaned properly. So that dirt, it has become ingrained, it has become part of the scar itself, right? It is like the patient has got a tattoo. This white dot that you see over here, this white dot, this is a miliary lesion. It is a miliary lesion. Okay. Now this is a midline neck contracture. This is a midline neck contracture. And from a whatever the cause is, that cause is not so important, but it is a midline neck contracture. So you can see where the patient would have had some injury, and the wound has healed in such a way. So you can see a scar of a primary intention over here, and the wound has healed such a way that it is pulling the chin below. So this patient, to in order to relieve his problems, this contracture needs to be released. Okay. Now the procedure that is being shown in this image, this is called a multiple Z plasty. So you can see over here, if you look closely, you can see this is Z shaped, right? This is also Z shaped. So this Z shaped incision, it is performed in order to release a scar or in order to refashion something else, right? So this is a multiple Z plasty which releases the finger contracture. Okay, so now what is this? So now in this patient, you can see this is the midline wound, right? You can see that the wound below this, so you can see sutures over here, but here the wound is left open. It may have undergone dissection on its own, or the sutures may have removed. But what is important here is that you can see a surgical site infection over here. You can see a surgical site infection. Now, along with the surgical site infection being present, if you look closely, you can see, yeah, this looks kind of darkish brown, black, right? And there's fluid present over here. So this is actually feces. These are feces, and what is actually formed is a fecal fistula, right? So fecal fistula has formed. So there is some communication between the underlying bowel and the wound. Yeah. Now this over here is a stoma. Judging by its location, it is in the right lower quadrant, so it should be an ileostomy. Colostomy is usually present in the left lower quadrant. One more difference is, how do you notice an ileostomy? So when you look at this stoma, it seems to be protruding out, right? It is pouting out. It is pouting out. So an ileostomy pouts, whereas a colostomy is flush. Let me write it over here. Colostomy is flush. So what do you mean by this flush? So flush basically means that it is at the same level. So now supposing say this is the anteabdominal wall and this is the stoma, it is at that level. It is not protruding out. Whereas a ileostomy is protruding out. That is the difference. So here is another patient who has got, so see, you can see different scars over here. This is the umbilicus. This depression that you can see over here, that is the umbilicus. This incision is in the right upper quadrant. And this is a midline laparotomy wound. You can see that there's some separation of wound over here. You can see that the wound is separated over here as well. But this looks healthy, right? This looks healthy. So basically in this patient, there is healing going on and it is taking time. If you look more closely, you can see some lines over. These are sutures, all right? And what this part, if I were to take a guess, it would either be the subcutaneous fat or the fascia. Okay, so now what are these that you see, these various openings that you see over here? So these are drains. These are drains which the surgeon would have put for after the procedure was over. Okay. Now in this image, you can see redness, right? And you can see that so this is the border of the redness, right? Roughly. But in between also you can see some amount of redness. So here also you can see redness, but you can see one more patch. I mean, one more area of redness. Let's not call it a patch. So this is actually cellulitis. So now what is cellulitis? Cellulitis is in cellulitis there will be redness, but there is no clear demarcation. So you do not know where the redness. I mean, it is not as clear for you to say that okay, this is where the cellulitis ends and this is where normal tissue begins. That is why it is it does not have that good a, so these are diffuse margins. The correct medical term would be a diffuse margin, right? And what you can see over here, these are blebs. This is a bleb, right? And the most common cause of cellulitis is streptococcus. So the most common cause for abscess would be staph, that is staphylococcus, and cellulitis would be streptococcus. Now this is again necrotizing fasciitis of the scrotum and the perineum, right? So this is, I discussed this earlier, this would then be called Fournier's gangrene, right? Now what is typical of Fournier's gangrene is you can see this structure hanging out, right? This is the head of the epididymis, this is the testis, and this is the spermatic cord. Same thing on the other side. Now, in Fournier's gangrene, the testis is characteristically spared. That is, the testis is not involved, right? Okay, so let's see what this image is. So now in this image, you can see red tissue in between, right? And you can see some white tissue or some slough in other areas. So these are the red tissue represents granulation tissue, and the where there's outright slough, that means that there is some infected tissue over there, right? And you can see slough in other areas as well. So this patient, he developed a mixed streptococcal infection of a skin graft with very poor take. What I'm sorry, what does this poor take mean? Poor take means that the graft, it was not taken up by the recipient, right? It was rejected. So very poor take means it was not poorly, it was not well accepted. That would be a better way to put it. Now, see, it is a mixed streptococcal infection. Now, what is important is that before you do any split thickness skin grafting, you have to take a culture, right? And group A beta hemolytic streptococcus, this is a contraindication for doing a split skin graft. So whenever you take a swab, and supposing if you find group A beta hemolytic streptococcus, that means it is a contraindication and you should not do a skin graft. Why not? Because the streptococcus, it has the, so you saw in a previous image also of cellulitis, right? Cellulitis is also most commonly caused by streptococcus. So now the thing with streptococcal infections is, because streptococcus, it produces those enzymes of hyalase and DNase and collagenase, it tends to have a very diffuse infection, whereas staph has a very localized infection. This is why staph produces abscess and streptococcus will produce cellulitis. Okay, so now what is seen over here? So this is a linear wound, right? And it looks like an incised wound with some wider separation in between. All right. So this is a fasciotomy wound, basically. Judging by the site of the wound, this looks to be a fasciotomy wound. And you see over here that this wound has been closed. So what happens in a fasciotomy is you are doing a fasciotomy in compartment syndrome. That is, you want to relieve the pressure in the underlying compartment, right? So that there is no gangrene which is happening. The threshold is 30 millimeters mercury. If it is more than that, then that is supposed to be compartment syndrome. Now, once you make the incision and you relieve the pressure, once the wound becomes healthy, if you wait for the wound to heal on its own, it will take forever, right? So, what you do is you can, once the conditions are favorable, that is when you can reoppose the wound and suture it again. So, that is called, either called tertiary or delayed primary. So, what are the types of wound healing? Types of wound healing is, one is primary, where you suture the wounds immediately. Secondary is you let the wound leave the wound open, you let it heal on its own. So there's granulation, contraction, and epithelialization happening in a secondary intention. What is a tertiary intention? Tertiary intention wound is a wound where, or it's also called a delayed primary, where you wait for conditions to become favorable and then you do a primary heal. So now the question arises, what is a split thickness skin graft? Is it primary, secondary, or tertiary? So now split thickness skin graft, you're not doing it immediately, right? You're waiting for the wound to become favorable. So that means you're letting the wound become favorable and then you are closing the wound, whether by stitch or by glue or by graft, you're closing the wound. So then that is also an example of delayed primary or tertiary healing. So again, in this patient, you can see that this is the abdomen, this is the margin, this is the margin, right? This entire thing is the margin, and this is the underlying tissue. So there is a healthy tissue over the fascia as well, and there is no gap. So basically, this wound was left open to granulate after laparotomy for fecal peritonitis. Now it is red, so now it is ready for skin grafting. If you wait for this wound to heal, it will take forever. Secondly, there is some amount of tissue loss, right? It looks like there has been some amount of tissue loss, or maybe there is adhesion on both these sides, here as well as here. So, judging by first appearance, by looking at this, it would not be possible to bring these two ends closer. It is difficult to make these two lovers meet. So, uh, it would be difficult to make these two lovers meet. So, you can cover it with a skin graft.